Thank you so much. Yes, autonomy. The patient has the right to decide. But the patient that has the right to decide must be what? Capable, capacity. That's why this life is very important. That they must understand the information you give to them, and they must be able to retain the information that you have given to them so that they can make informed decisions. And they weigh all the information available to be able to make a decision. And they can communicate such decisions by any means, either writing, talking, or sign language. So that capacity must be there. Because if they are not capable, they're not going to get anything. So they must have that capacity. So if that patient has the capacity, the patient has that right, the autonomy to what? To make decisions. So you have the right as the editor to what? You will let them know, like, but I'm not writing that. You let them know the reason why the patient needs to know. That the patient is somebody, and the patient needs to know what is happening to him. So that he can make decisions. In fact, the patient knows, the patient can say, we have seen like that. They will tell the family member that, let me go. Because most patients, although we are not taking statistics, but most patients, especially elderly patients or patients with cancer or chronic disease like that, they prefer to die at home. They prefer to die at home. And we all know it is cultural that people want to die at home. And also the hospital environment, people don't, because at home there will be people around. And they will be at their own, house convenience. But the hospital environment where the relatives are not allowed to sit down with them to talk seconds, so it may be very, very difficult. And people, naturally, they don't want to pass on the hospital. This is what happens sometimes when after the patient. You see, it's advanced, and there is really not much important, and we don't want to kill the persons. No. Because if we don't give it for the patient information, the patient will not be able to do that. So we know our patients that duty to tell them the truth, to let them know what is wrong with them. So, when the patient do good, you are acting in the best interest of the patient. Sometimes we have patients that metastatic, advanced metastatic CA breast, maybe to the liver, to the lungs, or to the brain. But those are three places that breast usually spreads. Lungs, liver, what, brain, LLB. So, we have patients like this. Usually we have the primary surgeons, the oncologists who are managing this patient before we are called to come and manage them. But sometimes, when patient is getting to end of life, there are some investigations that are not necessary, that will drain the pockets of the family. You can imagine a patient with pictures of metastasis, more than one, maybe two or more organs, liver, lungs, brain, dying. And some physician will say, go and do CT scan of the brain. Are you acting in the best interest of the patient? It's medical ethics. What do you want to do? What do you want to see? You want to do research? You want to confirm diagnosis? And the patient now, sorry, you really become doctor because the palliative care team, because the manner in which we manage our patients, they are more closer to us. They now come, doctor, what do you cannot shake? Papa, you say cannot shake. We now be taking what from the cancer. But now, look, some of these patients, they are trained, they are so advanced, they are so properties. Most of them are out-of-pocket, get nothing, they know insurance. And I put that whether any child has included cancer management in any child. So in this case, if you still tell the patient to go and do CPR, are you acting in the best interest of the patient? No. What the patient actually needs in the end of life is comfort care, communication with family, reverse what you can reverse, even outside of that, you can reverse, spiritual care. That's what matters to the patient in the end of life. The last 1 week, the last 48 hours, 22 hours, 48 hours, 24 hours, that's what matters. Compassionate care, dignity, oral care, ensure that nursing, good nursing care, and that's what matters. Not go and do CT scan, go and do MRI. But what benefits is that? These are medical ethics, which can be improved. Now, non-admissions. So that's when you are making a decision, it shows up the non-intention of doing that. Sometimes you want to act in the best interest of the patient. Sometimes. But while doing that, you discover that you are also harming what? The patient. That's what harming the patient. So it's not beneficence and non-admissions goes together. Fine, you want to do good to the patient, but this good I want to do to the patient, will it not harm the patient? You must ask yourself. So if it's something that will harm the patient, ethically, and leave that. Justice. I think I will talk about it that whatever you are doing, see just to the person, to the relatives, and to the healthcare system. Because distributive justice is there, the resources are scarce, and to ensure that you have a fair distribution. But you have to raise the best and not the head. And that's why even some of our patients that are dying, when we meet them and we organize the family conference, we usually tell them that palliative care can be practiced in the hospital, at home, and in the hospitals. We have given this building we have wards. Wards are 24/7 office. But due to lack of facility and lack of manpower, actually the manpower, cannot start. Doctors, nurses, we don't know the institution. We don't continue to help us. Because there are some patients that what they need is hospital care. When you make a diagnosis and you know the prognosis is 6 months, patient can go into hospital. Like I said, we have many. But again, into their mom. No. The one that started because of lack of patrolling, because of miscarriage, and that's the use. So we give them these options because some of our patients they have this problem. Now when we tell them about taking patients home, they will say, "Sheko Sheko, I fed Dama." They understand the implication of Dama. But here we don't talk about Dama. We tell them the options. Especially patients, there are some patients that they can do well at home. Especially patients that are not on oxygen. Even those that are on oxygen, most of them they don't need oxygen. They don't need it. The patient is on oxygen, they're consuming 6 liters, 12 liters, patient still is at home. I don't take the patient home to then come out of the family. Not yet. Instead of being on bed, wasting resources, people are not able to work. If you see what they go through, the relatives, you really pity them. So we meet with them and tell them that palliative care also can be practiced. And we tell them how to go about it. Usually when they get home, they can just get a carer. And if you have any challenge, we give them the drugs, the morphine, they are paying medications. And when they have any challenge, they can call us. It's just unfortunate that we don't have the wherewithal, the facilities to move around. Usually it's supposed to be going, we do it. Before, our mamas, the volunteers, so that's an installation. That's part of what they do for us. We go to their house, give them money, counsel them, pray for them, the chaplain, the imam, also follow them. But I think we stopped this when COVID came. Then after COVID, we are now back with financial subsidy removal. So even to fuel your car, you are just managing. Don't talk of say you want to fuel and go to Peregrino or that. When that's fast, for home visit. So this is what we do. And these patients can work. They can be managed at home. Patients already dying. And that's why we say one of our principles in palliative care is that we see life and death as normal process. It's normal. Not that we always run away from the truth. Normal. It's a process. It's a process. And like I said, that when a newborn is being delivered, you see the gynecologist, the midwife, they are welcome. When somebody is going the other side, somebody also must what? Follow them. And that's work of palliative care. They need people to support them, give them the social and emotional support at the point in time. So there's no big deal in saying to patients that you want to go home. We are not saying you're discharged. We will just say that patient is being discharged for palliative care. It's an option. But the only one that we can practice here is the hospital-based, where patients are in. The hospice is not yet to, we have not started. So the home is another option, which is cheap, which is comfortable for the patient and the families. They can sleep. They can even get a carer who just come in the morning, attend to mama, nursing, changing the diapers and all sorts. And they are drugged and they communicate with the palliative care team. So there's no really big, but take this thing as if it's because the problem that they go through is real. So looking at these ethics, when we have diamonds, we look at the ethics, the principle of ethics. The autonomy, patient has the right, and the patient does not have the right. It's not capable, maybe unconscious or the orientation is not really good. And the patient does not have advanced care plan. That's not the problem we have in this part of the world. No advanced care plan. But it will solve these problems. Patient will have written when I'm conscious, do not resuscitate, do not integrate, do not oxygenate. And there's the surrogates to no information. So we have to do our best to just act in their best interest. While we are trying to do more. And we also ask ourselves, what will we do in CPP there? If my patient or my relative has to be in this condition, we need to be clear to prevent it to remain like this. Getting not again, take my everything, be conscious and be correct. Go out, the relative is sleeping in the corridor, they cannot go to work. The right is an option. Patient can be cared to, get a carer which will be cheaper to even the hospital, and communicate with the patient. We can also visit if there's chance to do that. So that is what ethics is all about. I'm sure we have cases that we have seen and we have guidelines. I think we can also present that so that we can discuss that. Since that we have
that is one. If they say they had that to the point, that's one. So what means that when someone dies, they have the body, more than so on. One of the principal times is having to take, when they don't very immediately, having to take the thoughts in the hospital every other the community member. And that way, the institute for them. So I think, I'm not right, but that is why sometimes people are not of
Thank you, man. Yes, you are very right. But these are some of the things that they discuss with us every time we meet them. So they will tell us their fears, their concerns. Like you said, some will say, I'm going to get carer, or it's going to be sort of a problem for them, and also looking to patient, when the patient can eventually pass on. And even some they talk about death certificates. Yes. But here in this environment, what we do in palliative care in our department, questions, clarifications. Yes, you are right. But they can be taught. For example, there are some carers. Yes, there are some trained carers. Even people can use maybe the so-called auxiliary nurses. You understand? For this kind of job. You understand? So they can use them for this kind of job. Yes, can use them. You just train them. So they just will change their sheets to clean mama and mouth. No, you are not, but that's where you're getting it wrong. Wait, don't get it wrong. They are not. Don't get it wrong. Let me explain that. She said we are calling it back. No, don't get it wrong. Let me explain. You are employed this person to work in the hospital, but this person is employed to work at home. And even the basic care, anybody that was not even medicine or hospital can do this thing. Yes. What? But the auxiliary nurses are the ones that they use as carers in Nigeria for now. So we shouldn't deceive ourselves. So no, let's go into that. So, but what we are talking about is that at home, the auxiliary nurses they can function as carers. And they can do the basic things. Change your mat diapers, everybody can be trained to do that. It's not about encouraging quadring. Quadring is when somebody is now, in a facility, in a facility to practice what, has not the person gone through to them. So that's quadring. So we should get that difference. So any other thing, yes?
My own perspective, looking at it from the cultural angle, people believe that if you have children and then get to that stage of your life, that those children should be able to take care of you. And they believe that anybody that is being taken care of at home, that is because the family is not really interested in the care. So they believe that if the person is staying 2 months, 3 months in the hospital, is still far better than that person being at home. Some people can even agree with that family that they don't have money to take care of them. And if anything should now happen, in case of those people that do celebrate, are not the hospital in the way. Some people can, one way or the other, look from that particular background and insist that whenever you take them, you prevent the problem.
Yes, thank you so much. Yes, we know our culture. And that's the problem we have with having old people's home in Nigeria. You understand? Because they will say, particular about the city. We understand all these things. But what we are saying is that the patient has been in the hospital for so long, and we have discuss with the family who are concerned, who are the caregiver of this patient. And it's the principles of this ethics to see how we can help the patients and the families. So it is not left to them to now decide. Some will say, continue to do the hospital. Like the case I mentioned. After discussing with them, and we told them that what the patient actually needs is so they said, we want the patient to be good. So it's an option. But I think they also provided the service to them. It's facility-based service. So, like I said, palliative care can be practiced at home, in the hospital, and in the hospitals. So it's an option. But we should know that it's an option. Because some will even demand for that option because of the situation of the realities. Because some can imagine people that are spiritual money, but still borrowing money, and they are still owing the hospital. And I'm not telling them that, wait, man can be taking care of them, which they are not aware of. Because most of them are not aware that what mama needs can be taken care of at home. But by the time you let them know that mama can be taken care of, that's the situation. It will be a sort of a. But those who decide for cultural reason or whatever reason, to allow them to stay in the hospital to the patient eventually pass on.
I have to, when I was in my first, most of the time, she called me and it's about going to talk to her. About to tell you now. Don't think right to be against the books. You know, and looking at it, you're going to be sharp about treatment. Now, what do you want me to do in this scenario? Secondly, we talked about autonomy. I created a scenario with educational end-stage cancer. And as a doctor, I see that he or she is 25%. And looking at it, that we not really be beneficial because I rest. But at the end of the day, maybe the family of the patient now trying to find out that okay, using this type of this patient beneficial and now go medical legal. Now, how do we manage this autonomy medical legal? Thank you.
I'm sure we got that. Well, the first question is not clear. I got the second, but the first one.
I mean, during our function, we admitted a patient who had acute appendicitis. So we're very happy to theater. So she now called me. He said she wants to tell me something about her own history. It's part of the history. That she not even write the case notes. Now, as a doctor, it is beneficial for her health. That you know, I've been told you that don't even write that she don't tell anybody, a relative or possibly other medical headquarters. So what do you want me to do in this kind of pieces? Thank you.
Thank you so much. I don't know relate to you. I want to.
If the patient has mentioned that she wants to change her private no right to be paid by like we listen to that. If the information is vital to the management of the patient, then you let the patient know that this information needs to be passed across the data and care. We let her know. For example, African medicine. Let's assume at that time, HIV screening was not done. And then the patient have told that she's HIV positive. We let her know that FMC confidentiality, but for proper management of this case, I need to tell other doctors so that I can manage people better. And then let the person know that whatever you tell us, all other people are professional, they are not going to divulge this information unnecessarily. You understand? So I'm sure to say that the patient will allow the other medical will have that. It is something that will not impact on the care of the patient. Maybe the patient will need some counseling, you know. For example, maybe the person is going for surgery now, and the person is thinking maybe I will die. Now say, doctor, my child is not for my husband. You understand? Now, that one is not impact on the care of the surgery. So you transfer the patient, but after the surgery, maybe confine in a senior colleague and tell the patient that experience to help you discuss. You understand? So the summary that number one is that we look at is those ethics. Is it beneficial? And secondly, you don't want to do any harm. If somebody has an infection, you don't tell your colleagues, and then you now get infected. The patient will have done harm. So these are guiding principles. And even if it's not affecting the patient like others, and the managing physician, maybe the palliative care physician, the patient are not sick. So the patient now dies. If now saying, if the relative, maybe it's something from US, and say, why did you do CT scan? I'm going to sue you. No, so what we are saying in palliative care is that we are not saying necessary investigation should not be done. That's not what we are saying. For example, a patient comes in, maybe HIV positive, and suddenly the patient is presenting with weakness of one half of the body. In that case, is it HIV hepatitis? Is it stroke or something else? Is the patient hypertensive and HIV positive? So in such a case, you need to do a lot of investigation, do CT scan, brain, and other things to really be sure of the diagnosis. So we are not saying it's not necessary investigation. But what we are saying that sometimes in medical practice, it's not necessary investigation. You know, for example, I've seen a patient who had stroke, hemorrhagic stroke, unconscious, 70-something year old, unconscious, treating 3 days in the hospital, level of consciousness, not getting better, CT scan done to confirm that it's arriving. And then on the third day, the consultant is reviewing and saying, let's repeat CT scan to see if there is progression of the hemorrhage. You understand? What are we going to treat? And then also, you know, communication is very important. You have a situation where they say, go and do CT scan. And then one of the ladies met me and said, we want to go and sell our properties to do this CT scan. Because we believe that when we get this scan, the patient is going to get better. You know, that's it. The doctor said that CT scan is a test, it's not treatment. They said, no, we thought that it's treatment. You understand? So sometimes we don't discuss the patients. To let them know, this test is for this. For example, we tell the patient, okay, like what I don't say, HIV, okay, you are taking this HIV hepatitis, maybe like 6 months. So what to do is to find the diagnosis. If the patient says, doctor, we don't want you to confirm any other than just treat as you can. You understand? You can write in the case file. We want citizen identity. For example, there is one funny story I read or heard about that. A man went to the hospital for review, an 8-year-old man, and then he now saying, so in the social history, the man said that he's smoking cigarette every day for the last 20 years. He didn't have work every day, 3-4 bottles. Then doctor said, Baba, stop drinking alcohol, stop drinking cigarette. Baba said, why? He said, so that you can live longer. He said, I hate cigarette. I want to live longer. The Baba said, if I stop taking cigarette, I will die happy. So sometimes we have to plan, you know. So at 80, there are some people that are expecting death. You understand? That's why you see somebody who is 80-year-old. I know one man, 80-year-old. I think he had malaria. He took his load, he came to hospital and said, doctor, I'm sure I'm about to die. When we are talking about malaria, I say, hey, there's no more here. You understand? Because I died. Because they are fearing that if somebody is 80-year-old and his children brother of 70 dies, that number of 70 is not a bad thing for that 70, but it's a bad news for that 80-year-old man. So the 80-year-old is looking forward to death. But if we that we treat 80-year-old like 40-year-old, if I see a 40-year-old man, tell me don't smoke again. Even if I've been smoking for the past 30 years, go and stop it. You are going to die. And you meet for 80-year-old. You know, so the same with somebody is 80, it's unconscious. You are treated 48 hours, no improvement, that's not doing MRI. And you now say, if you didn't write MRI, somebody is going to take you to work forward. You understand? So you have to also individualize patient. Somebody is 40-year-old has a stroke, you need to visit time, you need to do everything. But 80 or something, even 90, you are not saying, so those are what you are talking about. So you are not saying don't do necessary, but unnecessary. And I know sometimes you talk to person that in this, how do you take it? You are not doing anything. Masterly inactivity. You understand? You already know that there is no cure again, but to seem as if we are doing something, just they say, okay, go and do me and do everything. But you already know that this patient needs better transplant. And you cannot do that. They say they don't have, that's it, do me and do 12-hour day. So that we can only all those things, wasting the patient resources. Thank you.
That's it for you. Let us continue to discuss. But in addition to what I said, I want to let us know one thing, especially when you feel it. There's a time we refer to as medical utility. That you will reach and say this is medical utility. That's at the time when any added investigation or treatment will not give any physiological benefit. So that you can say you have reached the point of what medical utility. At that point in time, asking for CT scan or MRI is a waste of money. And if you are being because of that, they will look at it. They will look at it. It's not as if you have neglected the duty. It's not that you are incompetent. They will look at it. Fine, I understand maybe abroad. The way they do their things, at times they sound excessive. I've seen the surgeon as even the surgeon. One surgeon you can use 8 gowns, changing gowns. Excessive thing like that. So, but that is the way they see it because of what? And because of, not because they think that it will give a benefit, but because of what? You fear of what? Litigation. That's the problem. And so, the people who are ordinarily, they don't do the high, which is even not good for the system. Even if you look at ethics, you will see that it's not even, the distributive justice is not yet, but otherwise they are running into problem. Their healthcare system is so expensive because of some of these high quality or small people, just because of what? Fear of what? Litigation. So thank you so much for your questions and contributions. Questions, okay? The last one,
They are people that we manage the show. It's a really level it's really it's one. Somebody said it's not put out for matching where to me talk Palliative team some so like food or anything. But unfortunately, the patient and quality, it's just not very big. Whether the not they thought that what the palliative care that probably that the end of life. So they reduce palliative care. And the palliative clinic starts job, I wish you could do it. The patient passed away at 20 after 10 minutes. So I want to ask, what is done right? When we know that actually it's thank you.
Yes, so it's a very we see some of these case scenarios of that when patients families refuse palliative care. You know, when someone refuses palliative care, you ask yourself, why are they receiving this? Why are they refusing palliative care? There are reasons for that. They will due to misinformation. In fact, some member of staff, when they are sent to palliative care, they don't know because of the misinformation that. Sometimes when we go to the world, we say, you didn't get objective, we are talking. Sometimes, that's what there's a particular doctor that told me, anytime he sees me, he says, so you can see misinformation about palliative care. So it's, we see, but sometimes we have been taught to see some patients, people with serious illness, not necessarily terminal, not dying patients. So it's not, palliative is not just about terminal, about dying patient, no. But let me finish. It's related, okay? Yes, let me answer. She asked me now. We have the dots that are still living. That's about that. We have the dots. I've mentioned some of their cases. Sickle cell patients, HIV patients, patient with molecular disease, patient with dementia. So it's not all patients that. Okay, yes, we have more cancer patients. So palliative is not just about.
She had had chemotherapies. About 12 courses of chemotherapy. She said, it's still about the drugs. Right? She's satisfied. She said, all the drugs went into my body. She's still alive. She's still well. She comes to the clinic every night. She's still very okay. She has medicine. So there are patients like that.
So thank you. So misinformation about palliative care, and just because palliative care is still emerging, you get the answer.
Well, thank you very much. I think we can see that you are going to pay you did trace about palliative care. I can tell you I'm a mental health professional. A large chunk of our kids are palliative. Suvera, for example, is a lifetime so that we continue to manage. Even when you grant drug medication, you still want to see patient. You understand? So these are some of the things, but because we are coming from a background of curative care, the hospital or mental health institution offer. I have this problem, I have this challenge. You want to use drug and take it away. That's what many people want. But many illnesses, even that we manage, are not like that. So palliative care is not about death. I was really surprised to hear that it came to no. And at any rate, most cases that lead to death are even active illnesses that can be cured if presented on time to the right person. You understand what I'm trying to do? So I think we need to apply ourselves more to understand the principle of palliative care and also the mindset that all of us have, including myself. Even as we work in a setting like this, we must know that health health goes beyond curative care. We have, in fact, it's not about preventive medicine going around now. When you are young, it's also amount to prevention of complication. Even palliative care in a way also cover preventive care. So the mindset of treating it and then the cure totally should be played down in most of the limiting else that we have to do. So I just like shipping is that palliative care.
We don't want to hear about mortality. Now, the patient that's attending, she had breast cancer and she has been using this fertility therapy, Rinso, or this popular Rinso. So we want to look at this to see if our patient are using some of these alternatives, what is our discussion as healthcare practitioners? How do we cancel them? And what are the options that are available in palliative care management of our patients? So I'll now call on our Director of Nursing Services, Agitmobi, who is the head of nursing in the palliative. Mr. Agitmobi, over to you, complementary on palliative therapy.
Good afternoon, today. I want to appreciate and I hope this really has impacted one or two of the work that we move on in this profession that we have to work process. Yeah. So no, if the following group are I want to really make that question. From Christian University representative among us, thanks for coming. This is our first time of going to US, and I think we are yeah. They're from College of Nursing. I don't you are welcome. We really appreciate your work. We went out to see how we respond to us. I thank God that we really had meaning into our invitation. And I know that if you have a plan, you will be able to have a little information to pass to the authority at home. We don't want to think they will do up concerning this curriculum development. Department, the Dept. So my presentation this afternoon is an alternative therapy. We all know that most of these patients that are having terminal conditions, there are a lot they are passing through. And by the time they are in the hospital to see, their main purpose for coming to the hospital is to get cured. And by the time the treatment is correct, and we have done this, we have done that, and they are not seeing any cure coming on their way, what do they do? Some of them went back to the alternate way. Meanwhile, some of them, even before coming out, they have been trying all this alternative way, but they want to complement it with the curative therapy. For some of them, when they get to us in the hospital and say, "Yeah, go see you at home. Go you are going to see mo lo àwọn ohun wọn ti bàbá ọmọ bàbá ṣe fún mi ó dẹ̀ máa ń wò ó ibẹ̀ ní tọ́ àgbo mi ti bó o ẹni dẹ́kun gbogbo problem mi ni and by that same time àwọn máa kọ́mẹ́ntì we are going to comment on chemotherapy surgery. This is working for them. And by the time you now scare them and say, no, we have to, they'll say, no, I'm coming up. You're not scare them. Some you are even correct them from chemotherapy, they are surgery, this and that, and they are using for a while, not changes. And we all know the effect of all these drugs matter. It's something, presented the case and everything. So by the time they try a little, it's not really well. They will talk back to Baba and say, oh, let's do this. And by the time they're not for they started your parents, started missing each other. They say, you are complicating this. Why are you taking another thing along with my own? Then you say, stop. No, I stop everything. I'm not using it. They are missing it. And you don't know where and that coming. So by the time you are able to be lenient, be able to get the necessary information, then you will know what I do. What I expect